Good morning. I'm here. My name is Meghna Sunder, and I'm here to talk about multiple sclerosis. So, when we hear the term multiple sclerosis, we have two parts. One is multiple, and the other is sclerosis. So, what does sclerosis mean? Basically, it means the formation of plaques, and these plaques affect nerves in the central nervous system as well as the spinal cord. So, history of multiple sclerosis. The earliest documentation of multiple sclerosis was back in 1395, when a 16-year-old woman named Lidwina developed an acute illness and fell while she was skating. She later developed symptoms of weakness, pain, and uniocular blindness, and was thought to be a saint. And later now, when we look back, we have discovered that she might have been having multiple sclerosis. So the first case was identified back in 1395, but the actual definition and the distinction between multiple sclerosis and other diseases was only made in 1868. And this was defined by Jean-Martin Charcot. And at the time, multiple sclerosis was referred to as la sclerose en plaques. He is of great significance because he made many significant neurological discoveries. And one of the important ones with relation to multiple sclerosis is the fact that he made the distinction between the tremors that are seen in Parkinson's disease and the tremors that are seen in multiple sclerosis. He also defined what we now know today as Charcot's Triad, which is not a pathognomic sign of multiple sclerosis, but can indicate that the patient does have it. And this triad includes intention tremor, nystagmus, and scanning speech. So basically, multiple sclerosis affects different parts of the brain as well as the optic nerve. So when it affects the eye, it can cause involuntary eye movements. It can cause loss of vision. It can cause optic neuritis. It can cause pain and double vision. When it affects the brainstem, it can cause difficulty with speech. It can cause difficulty while eating, talking, and swallowing. And if it affects the motor pathways, then it can cause spasms, muscle weakness, tremors, and ataxia. So an example of a case of multiple sclerosis that was seen in the clinic was an 18-year-old female with complaints of burning and tingling sensation over both legs and hands for the past 2 to 3 days came to the clinic. She was apparently normal 3 months ago, after which she developed burning type of pain over the groin, which was bilateral. The pain was intermittent and was treated with low-dose gabapentin. Due to the low dose, the pain was not controlled by gabapentin and the patient stopped taking it after a few days. The pain was associated with some amount of erythema, but there were no associated skin lesions. The pain eventually spread to both legs and palms of the hand over the last 3 days. The pain over the legs, thighs, feet, and hands was characterized as burning shock-like pain. The patient has a history of depression, a history of vitamin D deficiency, history of acute stress over the past 3 months. Her physical exam and cranial nerve examination, and along with the rest of the CNS examination, was found to be normal. This patient could, due to the presentation of pain and the distribution, she could have a demyelinating disease, such as multiple sclerosis. So multiple sclerosis, as a definition, is an autoimmune disorder that affects the central nervous system. So what happens is, the central nervous system is myelinated by these cells called oligodendrocytes. And each oligodendrocyte myelinates around 30 cells. And what happens is when a nerve or a neuron is myelinated, it allows conduction velocity to be increased. So the speed of conduction is increased, the space of conduction is increased, and this facilitates better neuronal transmission. So the disease is due to damage to the oligodendrocytes. Therefore, it affects only the CNS and the optic nerve because all other cranial nerves are myelinated by Schwann cells. So multiple sclerosis leads to severe physical, cognitive, or as well as neurological problems. It presents with multifocal zones of inflammation, which are composed of lymphocytes as well as macrophages. These zones of inflammation and oligodendrocyte death cause myelin sheath destruction, and this results in the formation of CNS plaques that can be seen on MRI. And these CNS plaques are composed of inflammatory cells and their products, demyelinated axons, and scar tissue, astrogliosis in both white and gray matter. These lesions basically cause crosstalk between the normal neuronal transmission and affect how nerve impulses are transmitted, thereby leading to significant neuronal dysfunction, which presents in various forms. It can present with autonomic dysfunction, it can present with sensory or motor dysfunction, it can present with visual disturbances as it affects the optic nerve, it can present with ataxia or cognitive impairment. It could also present with psychological disturbances such as depression, frustration, and fatigue. So in this picture, we can see the damaged myelin sheath. So myelin is very important for neuronal transmission. It provides an area of increased resistance. So when an impulse traverses the axon, it actually jumps via saltatory conduction from one node of Ranvier to the other. The nodes of Ranvier are points which are not covered by myelin sheath on the axon. So while bypassing the insulated area, it actually increases the conduction velocity. These nodes of Ranvier are also very high in sodium concentration, and this facilitates appropriate responses in the body. Etiology. There's no specific etiology for multiple sclerosis, but there are some factors that are associated with its increased risk. We have environmental factors and genetic factors. The environmental factors can be infectious, such as bacterial, caused by Mycoplasma pneumonia. It can be due to viral causes, such as Epstein virus and HHV6, which is herpes virus type 6. It can also be due to a vitamin D deficiency or vitamin B12 deficiency. So a vitamin D is very important for cell maturation and cell differentiation. So without vitamin D, the amount of immune cells produced is actually reduced, and it also may lead to immune cell apoptosis. B12 deficiency is required for myelin synthesis. Smoking is also a risk factor for multiple sclerosis. Smoking causes the production of nitric oxide and carbon monoxide. So nitric oxide actually causes by itself in large quantities is very toxic to myelin. So it causes axonal degeneration and myelin disintegration. Carbon monoxide, on the other hand, causes decreased tissue oxygenation, which impairs normal cell processes and it causes axonal degeneration. Exposure to UV radiation, UV type B, is associated with multiple sclerosis, and their dietary changes. People who consume high animal fat and who are obese are at increased risk of multiple sclerosis compared to other individuals. People who consume high amount of fish-based fat are actually at a slightly decreased risk of multiple sclerosis. A finding that was observed but has not been proved relevant yet is the association of linolenic acid with multiple sclerosis. An increased amount of linolenic acid is actually thought to be protective, but there is no definitive proof yet. The genetic factors are obviously very influential in the development of multiple sclerosis, such so that in monozygous twins, they share 50% of DNA. So around 12 to 15% increased risk of multiple sclerosis is seen in monozygotic twins. Whereas in dizygotic twins or first degree relatives, you only see a 2 to 3% increased risk. And as it progresses, a second degree relative will only have 1 to 2% risk of increased risk of multiple sclerosis. And a third degree relative will only have less than 1% of an increased risk. So the genetic factors include genetic as well as epigenetic factors, and there are positive protective factors and negative factors. The negative factors are found on chromosome 6, and they include HLA-DR2, HLA-DRB1, HLA-DQ6, HLA-DQA0102, HLA-DQB 10602, HLA-DR15, HLA-DRB1 1501, HLA-DRB1 1503. And also interleukin-7 and interleukin-2 receptor alpha. The protective factors are only two, which are HLA-C554 and HLA-DRB111. So when we talk about genetic factors, we also have to take gender into account. as per studies, women are more commonly affected than men, and it affects an age group of 20 to 40 years. Now, the prevalence that we see is around 120 people in 100,000 people tend to develop multiple sclerosis, but this can also vary based on temperature and location and other epigenetic factors. So the pathophysiology. So multiple sclerosis is mediated by lymphocytes and macrophages. So we have CD4 positive T cells, which are the main mediators of multiple sclerosis, along with B cells, CD8 positive T cells, and macrophages. So like everything else, multiple sclerosis it is caused by inflammatory factors, but you see a remitting phase, which is caused by the anti-inflammatory factors produced by the body. So both the disease progression as well as the intermittent phases with no symptoms are mediated by the immune system. So when we look at it, all types of cells, all the T cells, all the B cells, all the macrophages, they all are involved in both the pro-inflammatory as well as the anti-inflammatory phases. So the main T cell involved is the CD4 positive T cell, and it gets activated by foreign antigens. These foreign antigens may resemble myelin basic protein or a proteolipid protein or a myelin associated protein. And via molecular mimicry, it activates the toll-like receptors on antigen presenting cells, which facilitates production of interleukin 12, 23, and 4. These induce CD4 positive T cells to differentiate into thymocyte 1, thymocyte 2, and thymocyte 17 phenotypes. Thymocyte 1 and thymocyte 17 are pro-inflammatory, and thymocyte 2 is an anti-inflammatory phenotype. So interferon gamma and TNF alpha are the pro-inflammatory cytokines that are secreted by thymocyte 1. They promote inflammation and suppress thymocyte 2 differentiation. Thymocyte 1 is responsible for active inflammation. Thymocyte 17 is associated with autoimmunity, and thymocyte 2 is actually anti-inflammatory, prevents differentiation of cells to thymocyte 2, and facilitates B cell formation. These thymocyte 2 cells secrete anti-inflammatory cytokines, including IL-4 and IL-13. IL-4 reduces pathological inflammation and by increasing the production of M2 macrophages, which are actually repair macrophages, rather than M1 macrophages, which are destructive macrophages. IL-13 acts similarly to IL-4, but it also secretes matrix metalloproteinases that reduce inflammation. IL-13 is also known to reduce inflammation in allergic processes. Thymocyte 17 induces a large number of cytokines as well, including IL-17, IL-21, IL-22, and IL-26, which are capable of promoting inflammation. These anti-inflammatory cytokines are very important for the intermittent phases with reduction of symptoms. So in this picture, we can see the effects of each type of thymocyte. So initially, the pathogen is presented to the antigen presenting cell via the toll-like receptors. It produces the following cytokines: IL-4, IL-12, and IL-23, which acts on a CD4 positive T cell, differentiating it into thymocyte 2, thymocyte 1, and thymocyte 17. The thymocyte 2 reduces inflammation via IL-4 and IL-13. Thymocyte 1 promotes inflammation via interferon gamma and TNF alpha. Thymocyte 17 also promotes inflammation via interleukin 17, 21, 22, and 26. Once these promote inflammation, these act via the fast ligand death receptor pathway, which is basically a mechanism for apoptosis, which causes death of the oligodendrocytes. So these activated T cells go and bind to this fast ligand, which is a death receptor, and causes cell death. And once these oligodendrocytes undergo apoptosis and cell death, they are unable to produce myelin, and thus myelin degeneration occurs. And this is the basis for multiple sclerosis. So B lymphocytes, which are also a part of multiple sclerosis, produce TNF alpha, which promotes inflammation. They also produce interleukin 10 and TGF beta, which are anti-inflammatory. CD8 positive T cells can produce cytolytic proteins such as perforin. Perforin can be used to also cause apoptosis independently, apart from the fast ligand death receptor pathway. These cells all together increase vascular permeability, which facilitates influx of inflammatory mediators and triggers the death and destruction of oligodendrocytes. This is the general pathophysiology. So we have the anti-inflammatory cytokines over here, and we have the pro-inflammatory cytokines over here. An anti-inflammatory cytokine that I haven't mentioned yet is T regulatory cells, also known as marked by FOXP3 or CD25. These cells are natural protectors of the body, which prevent autoimmune mediated destruction of cells. And these are anti-inflammatory. And the thymocyte 1, TNF alpha, interferon gamma are all pro-inflammatory. Some factors that we do see are CCR5 and CXCR3 and CDD80, which is associated with macrophages. So here we basically have an outline of the whole process, which is basically the environmental damage causing T cell activation, which causes adhesion, demyelination, and injury, which eventually leads to neurodegeneration. You can also see here that it mentions the B cells, which produce these IgG oligoclonal bands, which is what is seen in the CSF. And these B cells react to myelin antigens, myelin basic protein, and other myelin associated proteins. So there are 5 types of multiple sclerosis. We have a clinically isolated syndrome, relapsing remitting type of MS, which is the most common type, primary progressive, secondary progressive, and progressive relapsing. So clinically isolated syndrome is what it sounds like. It's an isolated syndrome, which is one episode which lasts for about 24 hours. It may progress to relapsing and remitting type or another type of MS, which is what is most commonly seen, but it may not progress as well. And this depends on the patient. Then we have relapsing and remitting MS, which is the most common type that we see. So in this type, the patient experiences some symptoms as seen here, and then goes into a phase where without any symptoms, without any progression. Now this return may be to the baseline or not necessarily to the baseline. And with progressive relapses, you can see that the patient does not actually return to the baseline and slowly develops progressive neurological impairment. We have secondary progressive MS, which is thought to be the second stage of relapsing and remitting MS. It presents with a similar type of pattern where you have an active phase of disease and then you have a remitting phase of disease without the return to the baseline. And then this is the initial part of relapsing remitting MS, which then just becomes progressive. Then you have primary progressive MS, which does not present with any sort of phase in between where there's a return to a baseline with normal symptoms. It just progresses continuously. And this type is rapid and dangerous. And then progressive relapsing MS is also is a very uncommon type of MS. It is very rarely seen. In this, even during the baseline, there is actually a progression of the disease, which is unique compared to the rest of the types. So clinically isolated syndrome, like I said before, is a single attack, which is suggestive of multiple sclerosis. And there are certain findings that need to be looked at in order to define it as a clinically isolated syndrome. So these presentations can be monofocal or multifocal, and they may involve a variety of things. They may involve the optic nerve causing visual disturbances. They may involve the brainstem, and they may involve the cerebellum and spinal cord and cerebral hemispheres. And these respectively cause your ataxia or dysarthria or weakness or flaccidity, depending on which part of the central nervous system is affected. To be termed clinically isolated syndrome, the episode should last for at least 24 hours and should not be in the absence of fever or infection with no clinical features of encephalopathy. The course of MS after this is variable, and 1/3 of the patients begin with no disability and eventually progress to MS. And the remaining actually develop some amount of disability, which progresses. So it's more of a subacute type of syndrome, which is seen in young adults, basically between the age of 20 to 45 years. Most cases of multiple sclerosis actually occur between 20 to 45 years. There is a small proportion, about 1 to 2%, which occurs younger than 20 years and older than 50 years, but it's not very common. So while multifocal brain lesions may be present on MRI, in many patients, additional abnormalities may also be seen on MRI. This suggests that even though it presents with a single episode and we define it as so, it may have an extensive pathological process which has not yet been fully defined. So what are the prognostic factors with respect to clinically isolated syndrome? If it presents with monofocal symptoms, such as isolated sensory symptoms or optic neuritis, it is considered a good prognosis. Whereas if it presents with multifocal disturbances, you have ataxia, you have numbness, and you have tingling, and you have a lot of things affected, that doesn't look good for the patient or bode well. If the efferent systems are affected, that doesn't bode well as well. Then we look at the relapse rate. If the patient has a long relapse rate or doesn't have a relapse rate at all, that's a very good prognosis for the patient. Whereas if the patient relapses in 2 to 5 years, it shows that the disease is rapidly progressing, and this is associated with a poor prognosis. No disability after 5 years is associated with a good prognosis, as well as normal MRI. An abnormal MRI with a large lesion load, as well as substantial disability after 5 years, is associated with a poor prognosis. And this is obvious because if there's a large lesion, that means there's a lot of damage and a lot of destruction. And that means more things are affected and the disease is actually progressing faster. And here we can see a hyper-intense lesion, which represents what may be seen on an MRI with clinically isolated syndrome. So relapsing remitting multiple sclerosis. This is the most common type and affects most patients. During remissions, the most important thing to remember is the symptoms may disappear completely or they may continue and become permanent. There is no progression of the disease during the periods of remission, and it is classified into different types. So we have an active phase or an inactive phase, as well as a worsening period and a period which doesn't worsen. So an active phase may be with or without relapses, but basically active refers to new MRI activity or new clinical features. An inactive phase is when there are no new MRI findings or no new clinical features. Worsening refers to disability. So we're talking about, so a patient may be active and not worsening, as well as active and worsening, because the patient can have a relapse or new findings without progressing to disability, whereas the opposite may also be present, where the patient relapses and has evidence of new MRI activity with worsening disability. So we have to define which stage and which phase the patient exactly is in while we treat MS. So here we have a picture which describes what I mentioned before. So these purple arrows that you see here indicate MRI activity. So anytime we see this MRI activity, it means the patient is in active phase. Anytime we see this orange line, which indicates relapse, it also indicates the patient is in active phase. So when we see this blue line over here, so there is no clinical features, but there are MRI findings, and there is no disability. So the patient is in the active phase of the disease and is worsening because the patient does have a disability, but does not have it, is without worsening, sorry. It does not have a disability because the patient is at the baseline. Whereas if you look at these red lines, this indicates that the patient is worsening. And this particular point that we see here indicates that the patient is active with worsening disease with relapse. So this dark blue line that we see in the corner is stable without any activity. So there's no progression of the disease. The patient is not active, the patient is not worsening, the patient is just stable. So relapsing remitting multiple sclerosis presents with numbness, cognitive deficits, visual deficits, weakness, bladder and bowel problems. It also is associated with mood changes. I forgot to mention before, but clinically isolated syndrome generally affects the spinal cord. So you see patients presenting with ataxia or weakness rather than cognitive deficits. But these kind of cognitive deficits and neuropsychiatric changes are more seen in relapsing remitting type and progressive types of MS. Secondary progressive multiple sclerosis, it's generally, it follows an initial relapsing remitting course similar to relapsing remitting MS, but eventually it just progresses similar to primary progressive type. So it's like a mix of the two, and it's generally considered secondary to relapsing remitting. It's like the second stage of it. And it can also be classified as active or inactive, as well as with progression or without progression, similar to active or inactive with worsening or without worsening. So in this picture, we can again see the progression. Over here, the purple arrows once again represent new MRI activity. The red line represents active with progression because the patient's disability is increasing, the MRI findings are positive. The orange represents active without progression, but MRI activity is present. And this green line is not active because there is no MRI activity, but the clinical disease is progressing. So this is not active with progression, and this is not active. This blue line is not active without progression. So secondary progressive multiple sclerosis presents with worsening of symptoms even with treatment, or when patients have a greater degree of disability compared to the amount of years that they do have the disease, or a large amount of damage is seen on the MRI. Secondary and primary progressive types are harder to treat than relapsing and remitting types of multiple sclerosis. Primary progressive multiple sclerosis is characterized by worsening neurological function without any relapses or remissions, and can be characterized as active or inactive, as well as progressive or without progression. So in this picture, you can see it's basically just almost a straight line, because the disease is constantly progressing. There is no phase where there is no disability, there is no disease. The disease may be stable at some point of time, but the disease is constantly progressing. So that's why it's different from the other types. Progressive relapsing multiple sclerosis is the least common form, seen in 5% of the patients. Relapses do happen, and there is no phase of remission. There is no phase where the patient gets better. The patient is constantly getting worse. The thing that differentiates it from primary progressive is that you have relapses. You have phases of acute MRI changes, acute worsening with continuous progression of the disease. Whereas in primary progressive, the phases of acute worsening may not be present at all. So symptoms, when we look at symptoms, we have primary symptoms, secondary symptoms, and tertiary symptoms. So primary symptoms are sensory disturbances, which include numbness, tingling, burning, basically any sensory disturbances that you see. It is also associated with this sign called Lermite's sign, which is basically an electrical shock-like sensation which you feel over the body, which is a definitive pathognomic sign of multiple sclerosis. It's associated with walking difficulties due to spasticity, weakness. It's also associated with loss of balance and fatigue. Fatigue is very important in multiple sclerosis. A lot of patients present with severe fatigue and inability to do things because they are so tired. And this is a sign of progression of the disease, and this itself may cause walking difficulties without associated spasticity or weakness or loss of balance. Then vision problems. So multiple sclerosis is associated with optic neuritis. When we say optic neuritis, we think multiple sclerosis, but it can be present. It can also present with other things such as difficulty in movement, and this is associated with muscle weakness as well. It can present with intestinal and urinary system dysfunction, which can present with an overactive spastic bladder, as well as constipation or diarrhea. Cognitive and emotional impairment, inability to learn, and depression are seen in the more progressive types of MS. Dizziness and vertigo, and as well as sexual dysfunction, erectile dysfunction, and decreased libido are also associated with MS. Some other less common symptoms include swallowing problems such as dysphagia, speech problems, dysarthria. So both speech problems and swallowing problems are associated with brainstem lesions. So swallowing is considered the involuntary, it's not involuntary, but it's the unconscious half, where speech is the conscious half of it. So we know and we control our speech. We do control our swallowing up to a point, but beyond which. And then it's also associated with breathing problems, hearing loss, seizures, and headaches. Secondary symptoms include urinary tract infections, and it's due to urinary retention or it can happen because the patient is immobile. The patient may have a spastic or a flaccid bladder, and this may lead to urinary tract infections. And it's also associated with inactivity and immobility. Tertiary complications are social complications because the patient is depressed, the patient does not feel well, the patient does not want to go out, the patient is frustrated. And that has to be addressed as well because mental health is very important while treating a patient. You have vocational complications, which is associated with speech, psychological complications, and depression. So this picture represents overall the symptoms that can be associated with MS. So you have cognitive difficulties, difficulty thinking, confusion, forgetfulness, emotional changes, emotional lability, depression, difficulty swallowing, vision problems, breathing difficulty due to pain, fatigue, or vocal changes. You have change in your pitch, change in tenor, which is associated with dysarthria. Weak bladder control is which can cause urinary tract infections, diarrhea, or constipation. Weakened immune system, poor hand-eye coordination, numbness, tingling in the fingers, sexual dysfunction, brittle bones. Brittle bones is not associated with MS in a direct way, but vitamin D deficiency is one of the risk factors for MS, which progressively causes brittle bones. And then muscle weakness due to spasticity or weakness, and balance problems such as ataxia. So now for the diagnosis of MS, so when we look at the diagnosis of MS, we look at a lot of features. We have
Can we stop here? We have patients waiting. Dr. Stein, this is one half, and then maybe you have another hour of lecture yet. So let's break here at the Dr. McDonald's criteria. Let's break here, and then we'll continue again. Just patients are waiting.
Okay.
All right, thank you. Let me try again.
I apologize.
no problem, Dr. Stein.